Hello, yeah. Good morning, everyone. I am Dr. Sourabh Patwadhan, and I'll be speaking on my paper, Changes in Accommodation Facility with Varying Accommodative Demand. Mechanism of eye to focus in order to attain maximum retinal image clarity is called adaptive accommodation, and ciliary muscles are actively involved in this process and which are more prone to spasm as well as exhaustion. Apart from vision related abnormalities, the visual disorders including accommodative and binocular vision issues are significantly higher nowadays in younger adults. As a result of global adoption of digital screen, working distance has considerably changed, wherein users must quickly adjust the accommodation to focus on visual display unit and then relax their accommodation for distance things. This study is aimed to assess the variation of accommodation facility at different accommodative demand distances across refractive errors with fixed target size and testing flipper. So aim is to assess the accommodative facilities in patients with emetropia, low-grade myopia, hyperopia with varying accommodative demand, to assess the variation of accommodation facility at subjective working distance of at 30, 40, and 50 centimeters. So this is a cross-sectional study done over a period of 4 years. The study location was Nandadi Pai Hospital, Maharashtra. Sampling was random. We selected 70 patients, 70 subjects who were visiting OPD of hospital. They were not having any symptoms related to accommodation. Materials used were well-site rock card of 6:9 acuity and accommodative flipper. We excluded all patients who were pseudophakic or other problems in the eye. After baseline refractive evaluation, we checked for the accommodative facility. So at varying distances, the use of accommodative flipper of plus 1.5 and minus 1.5 is going to raise accommodative demand, and we'll be measuring the number of cycles the patient can clear in a minute's time. Going to the results, the distribution was 56% were males, and the refractive error distribution was 24 emetropes, 28 myopes, and 18 hyperopes. When we come to the results of accommodative facility, we found across all the groups that the accommodative facility was maximum when we used 30 centimeter as a distance for accommodation, while it started reducing to 50 centimeters. Across the three groups, we found that the myopes, hyperopes had higher accommodative facility, but we found that intergroup, when we studied, there was no statistically significant difference between the three groups. So in the discussion, the average accommodation amplitude of non-myopes were substantially higher in earlier studies than myopes. But in this study, we found that accommodative facility was slightly lower in myopic and emetropic subjects as compared to hypermetropic subjects at all three distances, 30, 40, and 50 centimeter, but it was not statistically significant. Now, though the accommodative facility was higher, again, it was not statistically significant. The binocular accommodative facility was always more as expected as compared to monocular accommodative facility at all distances in all groups. Now, this study showed that the accommodative facility is not significantly dependent on the refractive status, and irrespective of refractive status, the accommodative facility which can be corrected by vision. It is observed that accommodative facility decreases with increasing fixation distance. I think this was never documented. In fact, there are no studies in different distances of accommodation, whether it affects the accommodative facility, so we don't have any normative database as well. So we don't know what is the clinical implication, which should be studied further. Now, accommodative in facilities where the patient has asthenopia, and along with that, as compared to normal, they have reduced accommodative facility, it can be treated by different methods. So the further study can be concluded on these results with larger sample size, and secondly, we can also change the target size in respect to change of distance as well for the accommodative facility measurement. We are still working on how the clinical implication is of this changing accommodative facility over different distance of target. Thank you so much.
Thank you, Dr. Patwardhan. A very interesting question you have thrown up here. In this day and age when we are working at the intermediate distance a lot more than we are working at near, especially with the laptops, the tablets, and all these, the accommodative facility at a larger distance, that really calls for more studies.
Yeah. Yes. So that was the surprising finding. Actually, we were expecting that they might be similar, or patient might be having better accommodative facility at a distant object.
That is.
But it is opposite, in fact. And
Would it be related to your given that we're looking at an age group of 18 to 26?
yeah, young.
If we you see most of these problems start becoming a problem in the late 30s.
Yes.
So would it really, if we expanded the scope to
Yeah.
a larger age group and
So-
have a subgroup analysis?
Yes, sir. So initially, actually, we wanted to have a normative database for Indian people. That's why we
That
started.
would be a very interesting
Yeah.
this thing.
Because in Shiman, the standard, database shows that for 18 to 26 age group, 11 plus minus 5 is the, standard accommodative facility. But in fact, all our patients had less than that, 8, around 7 or 8 for 30 centimeter distance. And it reduced further on, changing the target. So as you said, we were expecting that at an intermediate distance, they should have better accommodative facility. Why it is less, and whether it actually has any clinical implication, that is, if the patient has less accommodative facility at distance and whether it causes asthenopia as you go, is what we have to study further. One of the reasons for reduced accommodative facility, which we thought of after going through, there is no study in the literature on distance, is that maybe it is the blur, because one of the stimulus for accommodation is the blur. So at 50 centimeters, probably the blur is less. So that's why there is lag of accommodation is more. That means latency for accommodation is probably more, and that's why patient has less facility. So that could be one logical explanation. But we have to see whether we should give certain exercises for those patients who have this lower facility, so that it may reduce their asthenopia symptoms. We are also looking into younger age groups now to see whether it has any role in myopia progression as well.
I think it has thrown up a lot of questions, and we need more studies to answer those.
Thank you, sir.
Thank you, sir.